imagine for a second that you are dealing with this terrifying, entirely baffling medical mystery.
Oh, yeah. The kind that just upends your whole life.
Right, like out of nowhere, you start experiencing this sudden, intense vaginal tightness or a sharp, painful burning sensation during penetration.
Mm.
Or maybe you're dealing with this persistent, heavy feeling like there's literally a foreign body just sitting right in the middle of your pelvis.
Which is incredibly distressing.
Exactly. And so you do what anyone would do, right? You go to the doctor, assuming there's some kind of localized issue.
Or you think, oh, it's an infection or a gynecological condition.
Right, something right there in the pelvic region. But test after test comes back completely negative.
Nothing shows up.
Nothing. You're prescribed, like, courses of antibiotics and antifungal creams, but absolutely none of it works. The burning persists. The tightness remains.
And you just feel crazy.
Yeah. And that is because the actual culprit, the actual source of all this physical misery, isn't in your pelvis at all. It's sitting several inches away, hidden in your lower back.
It's wild. It completely upends how we usually think about pain. You know,
It really does.
we are so conditioned to believe that where the body hurts is, well, exactly where the problem is located. Like if you stub your toe, the toe is the issue.
Right.
But the human body is this highly complex, totally interconnected network. And the relationship between the base of your spine and the pelvic floor is just incredibly intimate.
So our mission today for this deep dive is to answer a highly specific, honestly mind-blowing question. Can spinal issues actually cause a perceived and physical vaginal tightness?
A huge question.
And to figure that out, we are going to map out the hidden neuromuscular highway that wires your lower back directly to your pelvic floor. Okay, let's unpack this. Because for anyone out there listening who is suffering from unexplained pelvic pain or tightness, understanding this hidden connection could literally be the missing key to getting their life back.
Absolutely. To really grasp how something like, say, a slipped disc in your back can make a vagina feel physically intensely tight, we have to look at the wiring, the physical wiring that bridges those two distinct areas.
Right, the anatomy of it all.
Exactly. So
Yeah.
at the very base of your spine, right below the lumbar vertebrae, you have your sacrum. It's this triangular bone made of fused vertebrae.
Mm-hmm.
And exiting from these tiny holes in that bone are the syncytial nerve roots, specifically the ones designated as S2, S3, and S4.
Which, I mean, that sounds like a grid coordinate, right? But those specific nerve roots are basically the main power cables for the lower half of your core.
They really are.
And they weave together to form this major player in our nervous system, which is the pudendal nerve. But what strikes me is that this nerve, it doesn't just take a straight, easy path downward.
No, not at all.
It takes this wildly complicated detour.
A highly tortuous journey, honestly. The pudendal nerve actually exits the pelvis entirely, wraps itself super tightly around these dense connective bands like the sacrospinous ligament, and then makes a literal U-turn to re-enter the pelvis.
Oh, U-turn.
Yeah. And to get back in, it has to thread itself through this very narrow, unforgiving pathway known as the Alcock Canal.
And like a canal made of bone and dense fascia just seems like a terrible place for a nerve to be.
Oh, it's a nightmare waiting to happen.
I was picturing a house's main electrical breaker box. Think of your spine as that main breaker panel. And the pudendal nerve is this incredibly thick bundle of wires that has to run through a really tight, rigid, twisting crawl space.
That's a great analogy.
Just to power all the delicate appliances in one specific room, the pelvis. But I have to ask, if this nerve is so critical for bladder control, bowel control, sexual function, why on earth did evolution design it to take such a complicated, easily pinched route?
Well, what's fascinating here is that the pudendal nerve is what we call a uniquely mixed nerve,
Mixed meaning what exactly?
meaning it does a little bit of everything. Most nerves have a specific single job, but this one carries sensory fibers to feel touch and pain, motor fibers to tell muscles to contract or relax, and autonomic fibers to handle like involuntary functions like blood flow.
Oh, wow. So it's juggling a lot.
It really is.
Yeah.
Because it has to interact with so many diverse architectural structures. The musculoskeletal system for support, sphincter muscles for continence, highly sensitive tissues for sexual function. It has to physically weave its way through all of them.
Right.
It is the primary command center for the pelvic floor, providing sensation to the clitoris, the vagina, and the perineum, while also controlling the levator ani.
Which is that really crucial hammock-shaped group of muscles that literally holds up all your pelvic organs.
Yes, but that vast complexity is exactly its biggest vulnerability.
Because it's trying to do too much in a tight space.
Exactly. Because it is a mixed nerve,
Yeah.
any interference along that narrow crawl space doesn't just cause a simple, localized numbness. It alters sensation, muscle movement, and involuntary organ control, all at the exact same time.
Which brings us to what happens when the breaker box itself, the spine, takes a hit. Because of this direct wiring, physical anomalies up in the back can instantly cause just absolute chaos down below.
Total chaos.
And based on the clinical guidelines we looked at, the most common scenario for this is a herniated disc in the lower lumbar spine.
Right. We often hear the term slipped disc, but a herniation is really more like a jelly donut being squished.
Ouch.
Yeah, the soft, gel-like inner core of a spinal disc pushes outward through a tear in its tough outer layer. When it bulges out, it invades the space where those sensitive sacral nerve roots live.
So it's directly pressing on them.
So exactly, putting heavy mechanical pressure on the nerves before they even have a chance to travel down to the pelvis.
And it's not just bone or disc material that can crush these nerves, right? The sources also highlighted this phenomenon known as Tarlov cysts.
Ah, yes. Tarlov cysts.
Which are these fluid-filled sacs that can grow directly on those sacral nerve roots right at the spine. Cerebrospinal fluid essentially inflates these little blisters on the nerve root itself, acting like a constant, localized vice grip.
It's just relentless pressure.
But wait, let me just challenge the mechanics of this for a second. If I have a disc bulging in my lower back or, a cyst squeezing the nerve at the very base of my spine, wouldn't my primary symptom just be a sharp, terrible pain in my back?
You would certainly think so.
Right. Like, how on earth does a pinched nerve up in the spine translate to the vagina feeling physically tighter?
It definitely seems like a paradox.
Yeah.
But it really all comes down to a neurological concept called referred pain.
Referred pain.
Yeah. Your brain is essentially a central computer, and it's receiving millions of electrical signals from the ends of your nerves. Now, remember, the pudendal nerve terminates down in the pelvic floor.
Okay, right.
So when the root of that nerve is crushed or irritated all the way up at the spine, it sends a frantic distress signal to the brain. The brain looks at where that specific wire ends, and it completely misinterprets the location of the crisis.
Oh, wait.
It perceives the burning, the pain, or the heavy pressure as happening at the end of the line, in the pelvis, the vagina, or the perineum, not at the site of the actual crush in the spine.
Wow. So the brain is basically getting a corrupted file and projecting the error message in totally the wrong location.
Exactly.
It's like having a crossed wire in your house where flipping the kitchen switch somehow triggers the garage alarm.
That is a perfect way to visualize it. The alarm is ringing in the pelvis,
Yeah.
but the actual fire is up in the spine.
But the tightness itself, like the actual physical restriction that prevents penetration or makes it feel like hitting a literal wall, that's not just a phantom illusion, right?
No, not at all.
The vaginal tightness is a very real physical reaction by the muscles to those corrupted signals.
The pain might be referred, but the muscular reaction is intensely physical. When the pudendal nerve or those sacral roots are irritated, they start firing off these hyperactive, chaotic motor signals.
Just constantly firing.
Right. They are essentially screaming at the pelvic floor to brace for impact.
Yeah.
And the levator antemuscles respond by going into a constant state of spasm or guarding.
And the medical literature has honestly so many different names for this. Overactive pelvic floor hypertonia, or pelvic floor myalgia.
They love their terminology.
Yeah, but functionally, it all means the exact same thing, right? The muscles are locked in a rigid on position. They are clenching and absolutely refusing to let go.
And when a muscle is locked in a sustained contraction like that, it burns a massive amount of energy. But more importantly, a contracted muscle physically squeezes its own blood vessels shut.
Oh, wow. Cutting off its own supply?
Exactly. A muscle needs to relax to allow fresh oxygenated blood to flow through it. By staying clenched, the pelvic floor literally starves itself of oxygen. This creates localized ischemia.
Ischemia, which leads to a buildup of lactic acid, creating that intense, radiating, burning pain.
Yes, the burning is classic ischemia.
Because the muscles forming the vaginal canal are in this rigid, oxygen-starved spasm, it creates a literal tightening. It can lead to vaginismus or severe entry pain, making sexual intercourse incredibly painful or even completely impossible.
If we connect this to the bigger picture, think of it like a driver and a passenger in a car.
Okay, I like this.
In this scenario, the spinal issue, so the herniated disc or the cyst, is the driver. It is the one controlling the route and causing all the chaos.
Right.
The reflective pelvic muscle spasm, the physical tightness, the burning ischemia, that is just the passenger holding on for dear life.
You can try to calm the passenger down all you want, but until you take the wheel away from the erratic driver, you're still going to crash.
Wow.
The spine is driving the pelvic dysfunction.
Precisely. And while this chronic tightness and referred pain create just a miserable, often life-altering condition for the patient, it is generally a chronic issue.
Meaning you have time to figure it out.
Exactly. However, there is a scenario where this exact same neuromuscular highway presents an absolute immediate medical emergency.
And this is a crucial distinction. We've been talking a lot about chronic irritation leading to tightness, but severe and sudden spinal compression is a completely different beast.
Entirely different.
It's known as Cauda-Equina syndrome, or CES.
Right. Cauda-Equina syndrome is, thankfully, very rare. It occurs in about 1 to 3 in 100,000 people, but it is catastrophic if it gets missed.
Just catastrophic.
So Cauda-Equina, which literally translates to horse's tail, is the bundle of free-floating nerve roots at the very tail end of the spinal cord. Because they aren't protected by the solid cord anymore, they are highly, highly vulnerable.
Just kind of hanging out there.
Yeah. And when this entire bundle is acutely compressed, usually by a massive and sudden disc herniation, it doesn't just irritate the nerves, it cuts the signals off completely.
We've spent all this time talking about muscle spasms and, tightness. But for you listening, this is critical. The major warning sign for CES is sudden numbness.
Numbness, not tightness.
Yeah.
Exactly.
The clinical red flag to watch out for is a symptom called saddle anesthesia.
Saddle anesthesia is exactly what it sounds like. It is a sudden, profound loss of feeling or severe pins and needles anywhere a saddle would touch if you were riding a horse.
So we're talking about the genitals, the buttocks, the perineum, the inner thighs.
All of those areas, yes.
And the sources noted other major red flags too, right? Like a sudden loss of bladder or bowel control, or conversely, retaining urine and not even being able to tell if your bladder is full.
Which is terrifying.
Yeah. And importantly, for the context of pelvic function, a sudden, complete loss of sensation in the genitals during sexual activity.
If you have a history of back pain or sciatica, and you certainly develop these specific numbness symptoms, you do not wait for a doctor's appointment next week. You go to accident and emergency immediately.
It is a literal ticking clock. The longer that acute, heavy pressure sits on those nerves, the more the nerve tissue suffocates and dies.
It's irreversible if left too long.
Right. If the spine is not surgically decompressed right away to relieve that pressure, the loss of bladder, bowel, and sexual function can become entirely permanent.
It really highlights just how vital and honestly fragile that spinal-pelvic connection really is. When the highway is slightly blocked or irritated, you get chronic spasms and pain. When the highway is completely crushed, you get a catastrophic system failure.
Let's bring this back to the chronic scenario, though. The patient who is dealing with an overactive pelvic floor, the severe vaginal tightness, the relentless entry pain.
Right, the passenger holding on for dear life.
Yeah. Because the primary loudest symptom is being perceived in the vagina, patients and their doctors understandably look in the wrong place for a cure. It creates this devastating misdiagnosis trap.
It is entirely logical why it happens, though. If your eye hurts, you go to an eye doctor. If your vagina is burning and feels impossibly tight, you go to a gynecologist.
Of course you do.
But patients get caught in this loop of being treated strictly for localized issues. They are subjected to endless pelvic exams.
So many tests.
Right. They are given back-to-back courses of strong antibiotics for phantom urinary tract infections, which just destroys their gut microbiome.
Well, yeah.
They use antifungal creams for yeast infections they don't actually have. And the psychological toll of being told, everything looks normal down here, just try to relax, while you are in agonizing pain, it's immense.
It's gaslighting, essentially.
Practically, yeah. The root cause in the spine isn't even investigated because the medical specialties are just so siloed.
Now, to be completely clear, hormonal changes, specifically during menopause, actually can cause vaginal tightening and shortening.
Oh, absolutely.
It's a well-documented condition called genitourinary syndrome of menopause, which is caused by a drop in estrogen that physically thins and dries out the tissues.
Very true.
But that is a chemical hormonal issue. What we are talking about today with spinal referred pain is entirely neuromuscular.
And mixing up a neuromuscular nerve issue with a localized pelvic issue leads to one of the most frustrating and honestly damaging pieces of medical advice these patients receive.
Here's where it gets really interesting. And by interesting, I mean Infuriating.
Oh, here we go.
When a patient reports pelvic floor issues or incontinence, what is the default number one thing they are almost always told to do?
Kegel exercises.
Kegels. Core training. Pull everything up and squeeze. But think about everything we just uncovered in this deep dive. The pelvic floor in this scenario is in a state of severe hypertonia.
Yes.
It is already spasming, locked in a rigid contraction due to a corrupted, panicked nerve signal from the spine.
Telling a patient with an overactive, spasming pelvic floor to do Kegels is like telling someone with a severely cramped calf muscle to continuously flex their calf as hard as they possibly can.
It's just terrible advice.
It is actively feeding the dysfunction. You are taking a muscle that is already starved of oxygen and forcing it to work harder. It will make the ischemia, the burning pain, and the tightness significantly worse.
You are repeatedly contracting a muscle that desperately needs to stretch and let go. So how do we actually treat this? If a patient is trapped in this painful cycle, how do they break out of it?
Well, it requires true interdisciplinary care, addressing both ends of the nervous system. First, the passenger has to be treated. Specialized pelvic floor physical therapy is used to release the pelvic floor, not strengthen it.
And this isn't just regular physical therapy.
No, it is highly, highly specialized. Therapists use manual trigger point release to physically lengthen the spasming muscles.
Okay.
They also focus heavily on diaphragmatic breathing. The diaphragm and the pelvic floor are intimately linked. They actually move together like a piston.
Oh, interesting.
So when you take a deep, proper belly breath, your diaphragm pushes down, which forces the pelvic floor to drop and stretch. Learning how to breathe properly is a powerful tool to force those clenched muscles to finally relax and restore blood flow.
But calming the passenger only works long-term if you also address the driver.
Exactly. While the physical therapist is releasing the pelvis, a pain management specialist or a neurologist has to treat the spinal driver.
The root.
Right. This might involve precise nerve block injections to numb and calm the pudendal nerve, essentially breaking that cycle of panic signals. It involves fixing postural issues that are compressing the lumbar spine. Or, in cases where a herniated disc is severely crushing the root, it might require surgical decompression. You basically have to reboot the main breaker box while simultaneously untangling all the localized appliances.
It's all about stepping back and looking at the body as an interconnected ecosystem, rather than just a series of isolated, unrelated parts.
It really is.
So what does this all mean for you? If you, or maybe someone you love, is dealing with unexplained vaginal tightness, painful intercourse, or a heavy burning sensation in the pelvis, and the traditional gynecological treatments just aren't moving the needle,
It's time to rethink the approach.
take a step back. Look up the chain. Look at the spine. The wiring of the human body dictates that the symptom isn't always where the problem is. Your pelvis might just be the fire alarm sounding off for a fire that's quietly burning in your lower back.
This knowledge is incredibly empowering. It allows you to walk into a doctor's office and ask entirely different questions.
Absolutely.
If a localized pelvic treatment isn't working, asking, could this pain be referred from my lumbar spine or sacrum, can completely change the trajectory of your care and get you to the right specialist.
It really can. It takes the mystery away and gives you an actual roadmap. And as we wrap up this deep dive, there is one final lingering detail about this nerve connection that I just cannot stop thinking about.
Oh.
It completely shifted how I view the concept of pain itself.
This raises an important question about neuroplasticity, doesn't it?
Yes. The reality that experiencing chronic pain doesn't just hurt in the moment. It literally causes long-lasting structural changes to your central nervous system.
It rewires you.
Exactly. Your brain and your nerves physically adapt. They become more efficient at feeling pain.
It is a deeply maladaptive response. The nervous system is trying to protect you, but it becomes hypervigilant. The threshold for what registers as pain gets lower and lower until even normal...
Truly provocative thought to ponder. If a physical issue in your spine, a hardware problem like a bulging disc can, program your pelvic muscles to clamp shut and burn for months on end,
Yeah.
how much of any chronic pain we experience in life is actually just a software bug in our nervous system? What if the brain is just running a phantom defense protocol, locking our muscles down long after the original hardware injury has completely healed?
It makes you wonder if the inexplicable pain or tension you feel today is just an echo of an injury from a decade ago, trapped forever in the wiring of your body.
It really does. Next time your body is screaming at you, remember, the true culprit might just be hiding in the breaker box.